Contents of this is introduction, the review of literature, methodology, analysis of data, and summary. The title, excuse me, the title of my capstone project may make you curious as to why there needs to be a study on the seemingly obvious performance differences between novice and experienced nurses. I chose this subject to assess the performance of the two groups, to emphasize the need for nurses' continuing education. The results of this study, however, may be intriguing. Past and present nursing leaders of the Intensive Care Unit, or ICU, and the 81st Medical Group, the hospital where the ICU is located, attested that prior to the surge of Hurricane Katrina in 2005, the ICU had 14 beds and were always full. According to the interim 2012 chief nurse, patients ranged from pediatric, including newborn, to the geriatric population, some of which were in their late 90s. The ICU staff took care of their medical, surgical, and trauma conditions. The learning environment for the staff was rich, with bedside training of new nurses by their preceptors and guided by the clinical nurse educator. In services on new technology and research-based practices on hemodynamics and ventilator care, among others, were continuously updated through semi-annual skills fair and nursing grand rounds. Certification for critical care registered nursing, or CCRN, was encouraged by the ICU nursing leaders. In the aftermath of Hurricane Katrina's surge, the hospital closed down due to lack of electrical support. Patients were transported to other hospitals, and the medical and nursing staff were reassigned to other military facilities, as reported by the hospital public affairs officer. After a year, the hospital resumed operations with the ICU beds reduced to 2 initially. This is because only 8 ICU nurses were retained to resume care. The 2012 interim chief nurse stated that cardiothoracic, pediatric, neurosurgery, and trauma services in the ICU were no longer in operation, as the specialists had also been reassigned to other health facilities. The 2007 ICU commander observed that, quote, the low patient census and acuity made it difficult to maintain the level of expertise that ICU nursing demanded, end of quote. Furthermore, the previous staff development programs were not as fully implemented as it was prior to the hurricane. The new present ICU commander acknowledged that with the opening of a total of 6 ICU beds and the arrival of new staff nurses, assessing performance is now based on past experiences from other facilities instead of peer-guided training at the bedside done prior to the hurricane. The need for assessment of education and training has now become imperative according to the present ICU commander. Responding to this need, this capstone was proposed and later approved by the Hospital Institutional Review Board. So what is novice, expert, and expertise? Green and Gilhooly, cited in Keynes in 2002, states, a novice is a beginner whose performance lacks the speed, accuracy, and efficiency of the expert. Expert possesses a large body of knowledge and procedural skill in a particular area of expertise. In 2000, Erickson said, expert is any individual who has attained superior performance through instruction and extended practice. Expertise refers to the mechanisms underlying the superior achievement of an expert. In psychology, Chi 2006 states that expertise has been studied in 2 general ways. Absolute or exceptional expertise studies assume that creativity comes from the unique innate talent of the individual. The relative approach compares experts to novices. The goal of this approach is to understand how less experienced or skilled persons can become more skilled, assuming that expertise can be attained. Chi further defines expertise as a level of proficiency that novices can achieve. The definition of expertise can be relative in the sense that the more knowledgeable group can be considered the experts and the less knowledgeable group the novices. This capstone study follows Chi's definition of expert and expertise. Erickson, Pertula, and Coakley in 2007 explained that expertise requires performance consistently superior to the expert's peers, for example, chess champions. Expertise must have concrete results. For example, surgeons should have successful outcomes with patients. Expertise can be replicated and measured in the laboratory, for example, comparison of emergency nurses' performance with simulated scenarios to actual situations. Better, in her 2001 scholarly descriptive research, Novice to Expert identified levels of clinical nursing practice: novice, advanced beginner, competent, proficient, and expert. These levels were described by nurses interviewed and observed in small groups or individually. Findings show that novice does not have experience of situations they're expected to perform, while the expert operates with deeper understanding of the situation due to experience. Daly, in 1999, conducted 20 semi-structured interviews to analyze different learning processes by novice and expert nurses. The study showed that novices learn through formal mechanisms, for example, reviewing policy and procedures, reading journals, and experts learn less formally through peer dialogue to enhance knowledge and understanding of the patient's conditions. Studies using years of experience to measure expertise have shown that professionals may not become experts in a year's time. Hag, Heitman, 2008, Lehman and Erickson in 1997, and White, Ward, and Eccles in 2009 had those studies. With the expert performance approach, the fundamental premise is it is possible to identify the representative tasks of sufficient difficulty that capture essential activities related to superior performance. Tasks can be presented to novice and experts under standardized conditions to identify individuals who consistently perform superiorly. This Capstone project replicated White, Ward, and Eccles' 2009 study that used the EPA to examine behavior of novice and experienced critical care nurses in respiratory clinical situations using simulation. White et al. Study determined the relationship between knowledge and clinical performance of novice and experienced critical care nurses. Although deliberate practice activities that improve performance were identified in White et al. Study, they were not the specific focus. This Capstone, however, sought to identify deliberate practice activities of nurses using the DPQ, or Deliberate Practice Questionnaire. So what is deliberate practice? It is a form of practice that involves effortful, focused engagement in activities which improve current performance. This is according to Erickson, Kramp, and Tesh Romer in 1993. Deliberate practice is used in music, as explored in the study of Erickson et al., also in 1993. Studies of Baker, Horton, Robertson, Wilson, and Wall in 2003 showed that in sports, experts develop skills through DP performed under conditions of high concentration, maximizing cognitive and physiological adaptations. In Hag-Heitman's study in 2008 on expert performance in nursing showed that in critical care nursing, deliberate practice comes from experiences in other clinical areas such as the emergency room or post-anesthesia care unit or PACU. The study also showed that deliberate practice consists of engaging in lifelong experiential learning activities, learning from preceptors, attending seminars, attaining specialty certification, and reading references. My theoretical framework is Virginia Henderson's definition of nursing. Henderson in 1969 defines nursing in terms of the unique function of the nurse, which is to assist the individual in the performance of activities contributing to health or its recovery that he or she could have performed unaided if he or she had the necessary strength, knowledge, or will. Such assistance should be done to help regain independence as quickly as possible. This definition is elaborated in the 14 basic human needs that guide nursing care. In this capstone, the basic human need to breathe normally and its corresponding nursing component of assisting the patient with respiratory difficulties in the most expedient manner is addressed. Henderson also says that the nurse is viewed as the authority of basic nursing care. The nurse has the responsibility to identify problems in the specialty area and improve methods used. What is the relationship to my capstone? This capstone assesses the need for education and training of nurses working in the adult ICU and determines the education activities that can improve performance. On my methodology, the first thing is the purpose of the study. There are two of them. Measure differences between novice and experienced critical care nurses through performance of representative tasks in a simulated environment. These differences will serve as the basis for continuing education to improve staff performance. The second is identify DP activities that contributed to expert performance with the use of the Deliberate Practice Questionnaire, or DPQ. Participants were the ICU nurses from the 81st Medical Group in the Mississippi Gulf Coast. And there were 4 novice and 5 experienced nurses who participated. The novice nurses had minimum of 1 year experience working in the adult ICU, and experienced nurses had 3 or more years working in the adult ICU. All participants must be able to comprehend written English and willing to participate. This study is a quasi-experimental design based on the expert performance approach. 4 3-minute simulated respiratory scenarios were used to assess the performance of the novice and experienced nurses. Assessment of performance was based on the amount of time spent to attain and maintain oxygen saturation above 90%, the normal being 90 to 100%. Scenarios were piloted by 1 experienced ICU nurse. The Deliberate Practice Questionnaire, which was used by White et al., was revised by the principal investigator and tested by 2 experienced ICU nurses. The DPQ included demographics and activities engaged by nurses to improve performance. These are continuing education credits, seminars attended, specialty certification, study hours per week, and frequency of seeking information. So, descriptive statistics was used to determine the demographics of the participants. The Mann-Whitney U-test was used to analyze data for this capstone. This test assumes that A, 2 investigated groups are randomly taken from the target population. B, each observation or measurement corresponds to a different participant. C, data measurement scale is ordinal. And D, the sample is small. The Mann-Whitney U-test is a non-parametric test that uses the mean ranks of data. The Spearman's correlation, or rho, is a non-parametric procedure that requires ordinal data. Normal distribution is not necessary. The correlation coefficient is a number between +1 and -1, signifying the magnitude and direction of the association between 2 variables. Magnitude is the strength of the correlation, while direction tells how the 2 variables are related. If the correlation is positive, the 2 variables have a positive relationship. For example, taller participants tend to weigh more. Negative correlation denotes that the 2 variables have a negative relationship. For example, as self-esteem increases, anxiety decreases. My demographics. The average age for the novice nurses was 29 years. The experienced nurses was 35.2 years. 2 male and 2 female were novice nurses, and 3 male and 2 female experienced nurses. Highest nursing degree achieved was the bachelor's degree for both groups. Only 1 experienced nurse had a 3-year nursing diploma. 1 nurse in each group has a certification in critical care registered nursing, or CCRN, and 1 experienced nurse had a certification in emergency care nursing, or ECN. No statistically significant differences were found between the 2 groups. However, experienced nurses controlled the simulated respiratory crisis on average in 2.25 minutes, while novices took 2.83 minutes. The 35-second difference may be clinically significant to the patient. What is the relationship between performance and DP among novice nurses? Statistically, the DP activities did not affect their performance. For experienced nurses, there was a positive relationship between the performance and the seminars that they attended. But however, the longer it took for the more seminars they attended, the longer it took for the nurses to take control of the respiratory crises. The data on the type of seminars were not collected, however, so the PI was not able to determine if the seminar topics were related to the respiratory conditions in the scenarios. It is possible that the seminars were different from the respiratory scenarios and thus the positive relationship. The more reading was done, the less time it took to control the respiratory crisis, or there was a negative relationship. Therefore, deliberate practice activities can influence performance. Although no statistically significant difference was found in the performance of the novice and experienced nurses, the average scenario completion time in minutes between the two groups differed by 35 seconds. Results showed that the deliberate practice activity of reading done by experienced nurses influenced their control of the simulated respiratory crises. Assessment of performance differences between the novice and experienced nurses will become the basis for the nurses' continuing education programs. Deliberate activities such as obtaining CCRN, attending seminars related to nursing care of the existing patient population, and nursing grad rounds will be encouraged as approved by the nursing leadership. My limitations are: the participants in this Capstone project were limited to the ICU staff of the 81st Medical Group. Only 4 nurses, novice nurses, worked in the ICU, and all of them participated. Only 5 experienced nurses were available to participate. This is because 2 experienced ICU nurses were asked to test the DPQ and 1 piloted the scenarios. Other experienced nurses were deployed at that time. So what is the importance of these findings? The novice and experienced nurses can benefit from continuous education and training. Increased deliberate practice activities were shown to improve performance. As we said, the more reading done by experienced nurses, the less time it took for them to control the respiratory crises. For the DNP, he or she can be a leader in planning and developing guidelines for continuing education, which meets the DNP Essential 8 Advanced Nursing Practice. He or she can be a mentor by initiating, directing, and evaluating methods to improve patient care, which meets DNP Essential 3, Clinical Scholarship and Analytical Methods for Evidence-Based Practice. At present, I have planned, designed, and directed monthly simulated scenarios for shift leaders to present to their teams. The purpose of the simulation is to keep skills maintained and upgraded. The scenarios include map code, inserting pulmonary artery catheters, and care of ventilated patients. The above-mentioned tasks of planning, designing, and directing are the job descriptions of the Air Force Master Clinician, which is a new billet of which I was asked to apply for by the chief nurse. I recommend that increased sample size and a variety of scenarios be used, compare the effect of the simulated clinical performance to real-life situations, and observe the effects of the different deliberate practice activities on performance. The current 81st Medical Group Chief Nurse states that it is good to share knowledge and expertise to the next generation. If I have touched the nurse's heart to continue the research on deliberate practice and use the expert performance approach, nursing care will hopefully continue to improve according to evidence-based studies. Thank you for your time and attention. I am now ready for questions. Or not.
Josie, I have one question.
Yes.
Is how you accounted for the unequal sample sizes, or did it matter? Maybe the statistician can help with that, but you had 2 different sample sizes.
Oh, yes.
How did you account for that?
We partnered 4 of them, and the other one was an outlier. So that's how we made it with the man-with-the-U test.
Okay.
Right, Dr. Mike?
Well, the question about the table 1 and table you summarize your data and generate continuous data. We summarize like the mean plus standard deviation, and the category data we summarize the frequencies or the percentage. So you mix together and not label very well, and you're confused with me.
Okay.
Yeah, like you may market the mean and the standard deviation include next. The first one is continuous data. That's okay. The mean plus standard deviation. But the following is the category data. You don't have to mark the mean and standard deviation in the code. Just the mean in the standard deviation plus minus standard.
Okay.
The following category just the number following is the percentage in the group.
Okay.
That's it. Also like in the category, the factor there in the current the group there should be 5, but here the only 1 is 3. The 3-year nursing is 1, but you missing 1 number of the nurse in the current group. The education.
The diploma nurses, that's what you're asking about. That's the 3-year one.
Here the number also confused. The number you show the 3 bachelor and the 1 is 3-year nursing. In the percentage you say 80% and 20%. I confuse which one is there.
Oh, okay. We will fix that table.
Sure, yeah, right.
We'll fix the table because I don't know if it moved around as we pushed it out, but I have a separate table that will put out what's supposed to happen.
Okay.
Yes, sir. Yes, ma'am.
You described several deliberative practice activities, including the simulated scenarios, reading, seminars, and grand rounds. Is that correct?
Correct.
But the only one that was statistically significant was the reading. Okay. So as you move forward, will you continue to use all of them or just the reading?
I will continue to use all of them because it depends on what the need is. What I plan with the reading is we will have articles that are going to be read based on the patient population and have a discussion about them. So there is a relationship between what's outside and what's inside. Because what reading has is it gives us a better view of, let's say, a patient condition. Not only what we're taking care of and what the doctors tell us what to do, but it helps us have a better understanding of what the condition is, and that helps a lot with performance.
And I have one other question. Can you share with everyone here the position that you've been invited to attend? And I think it's very important because when we think about DNP Capstone projects, we try to look at things that would be sustainable over a period of time. So what will this new position that you will apply to and hopefully be granted help you in continuing this?
Right. You know, this fellow, before I went on leave for this, I had an interview with the chief nurse, and she said, we are having a vector. I don't know if Dr. Wang knows that, but vectoring is about putting military personnel in places like billetings, that's what they call it. Mm-hmm. And they opened it to civilians. Mm-hmm. And they said, and I said, what's the job description? And it's exactly what's directing, planning, all the things that I had in that capstone was right there. Yeah. And she was telling me this, and I was like, oh my gosh, I can fit that. I am right. But at the outset, I already told her I am about to get, I'm about to finish my DNP. Oh, that is so nice. Okay, fine. So in other words, I feel confident, and of course they're going to have determinations of this, and I did not have the chance to to apply it because it came down January, and it was too quick, and it's just February, and he said, just apply for it, and we'll just push it in, and then we'll see what happens. But this is a new billet done in the Air Force in 2007. What happened was, those people that are in administration and clinical education were the ones being promoted. Those people in the bedside were not. So nurses left. So what happened was the Air Force was looking at this, why are they leaving? Because they don't want to leave the bedside. So they made this billet master clinician. So this master clinician is right up my alley.
Okay.
And she said, I don't have to explain to you, you know it already. I said, yes ma'am, I will definitely help you out. And of course, you know my plan from the get-go, and I said, I'm going to retire in 2014, but it became open.
Right.
And I'm willing to, I'm still willing to do this because, you know, it's still bedside, but I'm too old to turn patients, you know. and pull them out.
You can be a change agent in the ICU setting.
Well, actually I am now, but I mean, it's like, I always have to put them, anyway. Yes, well, because these people are new. They haven't seen the pre-Katrina ICU.
Okay.
And so everybody's asking what, and I just keep quiet in one corner until I'm asked. But it's a change. I don't want to appear, yes ma'am.
Your study is very good, and you know, there's not a lot, according to your review of literature, information out there specifically about what you did in the discipline of nursing.
Correct.
As you said, but you know, you really should continue it and develop this.
Yes.
If you can.
I'm planning to do that, depending on my stamina and health. But I mean, it's worth going forward because there is a dearth of DP in nursing, deliberate practice research, and I looked into it, and it was that. The DP is not there, and the EPA. Well, I'm grateful that Erickson just spearheaded that, and White and well, Eccles started going through it, and you know they're also nurses, although they have PhDs. Yes, yes, ma'am. Oh, yes, yes.
You mentioned you found significance in the reading component. Is that what you expected as an outcome, or did you expect to find significance in some of the other areas?
I was expecting more than that. I was expecting at least hours of study. It just hurt me when I saw that it was reading well, of course, because every time, this is one thing good about the ICU, every time they come in, they're told to do the basic critical care course on computer. We used to have it in face-to-face lecture, but now it's the BCCC, whatever it is. But they were told to do that, but it's a long program. It takes them months. By the time you finish it, their mind is not there anymore. Plus the fact that you don't have patients to apply that for. So it's gone. And so when you have a real active patient, what did you learn? So I was expecting hours of study to come together, but reading was way up there. I was surprised I was going to change the data.
But you know, a bigger sample size might make a difference.
Very much.
What you found.
Very much, very much. Yeah. If I had enough experienced nurses, I think there would be, the people that were deployed came back, and they were good people. And I said, Miss A, you're going, they call me Miss Alejandro, Miss A for Alejandro, and I said, I'll be the outlier, because they're more than 8 years experience. These are 3 and maybe 5 years experience. But they had 15. So, yes, ma'am.
Could you tell me a little bit more about how you, you said that you tested the questionnaire after you adapted it with 2 nurses. Can you tell me a little bit about that?
Okay, we had a DPQ that came from Dr. White, and he shared it with me. And from there, my Capstone chair and I had done a little bit of tweaking in it, and he said you can tweak it because I've used it in different researches, and by all means just tweak it depending on your research. So that's what we did, and I asked 2 of them.
Wasn't it about 50 pages long?
It was, and it was not relevant. It wasn't relevant to the research, and why would I do that to the poor people, right? Nurses are easy enough to look at it. So anyway, the less streamlined it is, it was better. And they just checked it. But I asked two of my experienced nurses to do it, and that eliminated them already outright. And
So they were not included in the study?
No.
It was just for timing.
Oh,
more than anything.
yeah, that's what when you said testing, I was just trying to figure out
How long?
Yeah.
psychometric testing.
No.
Okay, it was just more fill it out. Okay.
Yeah, it's
Just wondering.
it's the demographics, how old, not how, yeah, how old and how, what is your basic nursing degree, and then all the continuing education that you had, the years of the seminars you attended, those were the ones in there.
Did you happen to ask them for any feedback on the questionnaire to see
Oh,
if any of it would maybe needed further tweaking?
No,
No.
no. They were just happy to participate, and I guess, you know, not that they're rushed, but it spelled out what I wanted, and maybe they had some questions, some of them were really thinking, but no, it wasn't an issue.
So the information that was in the questionnaire that was the information you reported to us in your presentation? Okay.
Exactly
All right.
what they are.
Okay.
Right.
All right.
Yes, ma'am.
So, given all the work you put into this, from your education and all of the work on your project, if you had to give advice to another DNP student about to enter the same phase in the process, what would you tell them? What do you think you've learned through this process that you would like to share with another DNP student?
Overall, stamina, your own will to finish it, because it is not going to go away. If you want to stay, it is not going. If you plan to do the DNP program, it's the best one that ever came out of the nursing profession. Purposely did not want to go to doctorals because it takes so long. But when the DNP program came 2002 and even before that, it was like, this is the one I want. And I will not rest until I get it. My husband said, you're crazy. Yes, I am. But it could have been when I was 40, when I was growing kids. No, I cannot do that.
It takes perseverance, doesn't it?
Oh, yes, that's another word, is perseverance. And it's really your will to do it. It's perseverance, and you learn. You really learn. And, you know, and that's one of my pet peeves. If you don't learn something, you're just not gonna make it. It's just, the world out there it's tough. So if you get through this is baptism by fire. And I would recommend that all people that will be coming after us have that stamina to do it, the knowledge.
And I'd like to piggyback on Dr. Harrison's question, asking the same question but a little bit more specific. And the stamina is very important, but if you had to think about in the last year. What was your question, Anita?
What she learned that will help other people?
Yeah, what have you learned that will help other DNP students, those that are starting on their projects now, as they go through it over the next 6 to 9 months? Hopefully not 9, but 6.
Be open-minded. Be open-minded. Change, things can change.
Okay.
You cannot be in one road only, and that wasn't what I was thinking for my project. No, because you don't know what the other people see.
Okay.
And that's one thing I learned. I mean, this project was an evolution between me and Sybil. It's like, I have a stack of papers this high, and how many prints did we make for this? And then I said after the whole thing, some people burned them. No, I won't. I'm going to
Make some valuable information in there.
oh
right?
my gosh, it's dust and everything, and we know dust mites can give you allergies, but that one I
Hey,
think.
you're going to need it for publishing and doing extended studies and whatever you decide to do with it.
That's another thing. You may not know that this is another place where you can find an idea of if you want to practice research. Well, that is one thing that nurses have to do anyway. I mean, the value of research in nursing is it is something like right now, evidence-based practice is where we are going. We cannot go by tradition. Oh, I did this path this way before, and until now it's going to be the same. No, it's not going to happen. So evidence-based practice, if we have to push nursing, we have to go that way. I'm glad we have the DNP program. The Marco Rubio. Yes, my daughter.
Do you think that if you present this to the Air Force, I don't know if you have already, you've kind of not talked about it, do you think that that would be a good suggestion for all other hospitals, you know, expanding the study, but actually saying, hey, I'm a master clinician, let me show you how this study can help, you know, all the different hospitals, because there are major hospitals everywhere, and including the VAs on the coast. I mean, is this something that you might want to, you know, reach out and share?
You know, in a little seminal way, I have, but they're not receptive. For some reason, because I asked for participants from each of the ICUs in the coast, and they did not answer me. In other words, we're hiding under some kind of a bushel, and I don't know. And finally, when I was going to get the IRB, I was thankful that I did not get them, because it would have been a nightmare, because it had the approval of the VA, approval of Garden Park, approval of Memorial, approval of... I won't be here. When the IRB came down from Keesler, they asked me, do you have other participants from other hospitals? I said, no. Oh, good. Oh, good, because we will have to streamline it, and Dr. Wang would go crazy. It would be nice. It would be nice, because I have many participants, but nurses, again, are coy to give their performance. Even in my own participants, they said, Ms. A, is this going to affect my rating? And I said, no, this is research, and it's not going to affect whatever you... And you know, this is like a game, you know, just go ahead, this is a scenario, we just go ahead, it's like ACLS and BLS, and so they played, but some of them want to please us. Oh, I made it wrong. Will it? No. Mannequin's not gonna die. You're just gonna be okay. I'm just 3 minutes over your time. I mean, you're brain dead. But you know, mannequin is mannequin.
But your daughter brought up a very good point. You can take this pilot that you've done and affect change in practice in other military hospitals. Is that what you were saying?
The Air Force, and she's already in that branch.
Right.
Yeah.
Yeah,
Oh, yeah.
question. If you really want to say the general population, you have to pick the sample from the general. But here, in her study, we limited the samples from the Keesler Air Force Base Hospital. So we cannot generate the concording for general.
Right.
But that should be the reference. We can maybe have the clue. Yeah, they have the different. They have the clue. We can't see it. Other hospital may be, but we cannot have direct evidence from her study.
Right.
Oh yeah. I was thinking it would go vertical, because that study can be applied to the medical surgical floors. And that was made the way it is. I mean, the nurses up there, medical surgical nurses, need this, because there's a continuing education program. That's why I said, what if they ask, why do you need a study for continuing education? Because they're giving us so much, but it doesn't hit the right spot. You have to assess first, what do the nurses need? If you're giving them, we were given EKG test by our CNS, and they didn't put a dent on us, because we were not EKG people. We're taking care of them. We're not the technicians. So when she put it out, 100 pages of that, and read the EKG, we did. And then what? What was the application? What's the performance?
Right.
So what if there is a third-degree block? Does it help? So yes, sir, I agree. It will go upwards, and hopefully when this master clinician moves forward, I'm hoping the nursing leadership will be more open, because I tried that way also, and of course there's always that resistance. It's too hard. But it's done. It can be done.
Maybe your family would like to talk about how much they suffered through your...
Okay. Sybil, I have a target, like a dart target of your face right now. I'm being facetious. But honestly, I write reports all the time and have people review them. And I mean, there's bleeding reports. I'm like, Mom, she said something again. You know? So no, but we like a diamond doesn't get shiny and bright without getting hit and faceted. And
Good point.
I appreciate all your hard work, and and even my dad being my mom's sounding board, just amazing. And it was tough. It really is. And Mom is not computer. Did I send my online class, my paper? Did you make sure? It's like, Mom, it says sent. Oh, just check it again. So that was very like. But I keep going back and saying, she helped me when I was trying to get scholarships, trying to get to Southern, my honors college papers. She read through them too. So, I mean, I owe her, and. I know we were just joking earlier, can we get our cap and gown fitted too, while we walk across the stage with Mom? But it was difficult, and I understand, Mom said stamina, perseverance, but you've got to have family and friends that are going to be, to help you. And, we had our church, parish friends, all with different knowledge backgrounds saying, can you help me with my statistics homework? Can you help me with da-da-da-da-da? So you've got to, like I said, take a village. You need everybody, and it's just going to be so much sweeter. Hopefully, the panel agrees when this is all done to award you. And it was tough, but worth it.
And then you can call her Dr. Mom.
I know.
That title is like, well, it's there, but there's work to be done. I always look at it as there's work to be done. I'd rather not think of the crown because it stops you on your tracks. And I'd like to move on. Okay? So it's more like, okay, I'm going to settle down in good old Philippines and enjoy the sunshine. It's not going to happen yet until I finish what I'm supposed to do in this earth. I'm really happy. I wish I could put them all in the acknowledgement, but Zigo's going to kill me if it's two
We
pages
don't want
long.
that because I might,
Yeah. I even did not write her last name and got her married name in there. But the people around that acknowledgement were the people that helped me a lot. And unbeknownst to Miss Sybil here, it was like, man, you pray hard, thank God, it's just that way. But when I embarked on this, I really had to ask God, do you really want me to do this? And there were signs, and there were big signs. I said, okay, let's go. and thankfully, well, Dr. Butts, I owe the thanks also for sending me to Sybil, because I asked Dr. Butts first. I didn't know the faculty. So she said, oh yeah, Dr. Harrison can go. And I said, oh sure. Thank you. Man, that was good. Yeah, but that's where we are.
Well, it's been a growing experience for me too, and I appreciate your patience and all of your hard work. But unless anybody has any more questions, everybody but Dr. Wayne and Dr. Butts and I will leave the room.
Oh, do you want to go over the Learning Center?
No, we can stay here.
Okay, I mean,
Oh, them. Okay, I don't.
There's a sitting area right across the hall, that little learning